Kevin McDonald is a 35-year-old man who received severe flame burns of his legs and wrists. As Kevin was refilling his lawnmower, some gasoline spilled onto his jeans and the hot engine. The fuel flashed and Kevin was on fire. This program will focus on Kevin's care 3 days after the injury occurred.
Burn injuries are one of the most difficult injuries a patient can experience. An extensive burn can be very traumatic for the patient, both physically and psychologically. Each year, 2 million people are burned. Between 6,000 to 8,000 will die as a result of their burn injury. Because of the systemic effects of the burn injury, psychologic implications, and prolonged hospitalizations, comprehensive nursing care is required during the acute and long-term recovery phases. In this video, we'll be covering a brief review of the etiology and epidemiology of burn injuries. We'll look at the pathophysiology of burns and a brief overview of the emergency treatment of burns. Priority nursing assessments will be discussed, followed by key nursing diagnoses and nursing interventions. Approximately 80% of accidental burns occur in the home. Death rates are highest in children and the elderly. Men are burned more often than women. There are 4 mechanisms of burn injury. They include flame burns, scald injuries, chemical injuries, and electrical injuries. Flame burns account for 50% of all burns. Often the smoke inhalation associated with a flame burn can be as damaging as the thermal injury. Scald injuries make up around 33% of burns and are the most common burn for children. Chemical injuries account for 10% of all burns. The extent of the burn depends on both the caustic nature of the chemical and the length of exposure. Alkaline burns are usually more serious than acid burns. Electrical injuries make up less than 10% of burns. With electrical burns, the burn gets worse as it continues through the body. It often takes several days to determine the extent of the electrical burn injury. There are 2 major complications for patients with burn injuries. Infection is a major problem once a patient has been stabilized from the acute stage of the burn. And scarring is a major problem, not just cosmetically, but for freedom of movement as well. A severe burn may have psychologic, physiologic, and social consequences that permanently alter the quality of a person's life. The family or significant others should be included in the treatment regimen from the time of admission. Family and friends should be encouraged to visit the patient in the hospital. This helps to ease the sense of isolation the patient may feel. In addition, visiting the patient allows the family to observe wound healing and changes in the patient's appearance. They can begin to understand the patient's day-to-day struggles and gain some insight into the problems and goals of emotional and physical rehabilitation. Burns have both short-term and long-term effects. In the short term, following a burn, the protective layer of skin is lost. This can result in fluid volume deficit and hypovolemic shock. The fluid volume deficit occurs from either external fluid losses or internal third spacing. The loss of the protective layer of skin also means that microorganisms can more easily enter and cause an infection. Long term, if a burn is a full thickness burn, there can be significant scarring. This scarring may limit mobility by developing contractures if the burn extends over or is adjacent to a joint. Traditionally, burns were classified as first, second, and third degree. However, burns are more precisely described as superficial, superficial partial thickness, deep partial thickness, and full thickness. A superficial burn is best exemplified by a sunburn. This type of burn affects the superficial epidermis. The injury leaves the skin pink or red, dry and painful. The affected epidermis sheds in approximately 1 week without leaving a residual scar. Superficial partial thickness burns involve both the dermis and epidermis. These burns produce a wound that is blistered or wet if the blister has been broken. The wound is red and it blanches and refills when pressure is applied. These wounds are quite painful. Deep partial thickness burns produce a wound that may be dry and mottled and may or may not blanch. The wound may be painful or insensitive. Deep partial thickness burns will take at least 3 weeks to heal, and almost all heal with significant scarring. These wounds are best treated with early excision and grafting. A full-thickness burn destroys the epidermis and dermis, so the skin cannot heal without grafting. An extensive full-thickness burn can also involve fat, tendon, and bone. Full-thickness burns vary in color from white to black or charred. The wound appears dry and leathery as a covering of denatured protein called eschar develops. The wound itself may not be painful since the superficial nerve endings within it have been destroyed. However, wound margins are extremely painful. Burns are categorized by the American Burn Association as minor, moderate, or major. Minor burns are classified as less than 15% total body surface area in adults, with less than 2% full thickness loss. Moderate burns include partial thickness burns of between 15% to 25% total body surface area, with between 2 to 10% full thickness burns. Major burns are those with greater than 25% total body surface area or greater than 10% full thickness burns. Burns that involve hands, feet, face, or genitalia are always considered major burns, regardless of the size of the burn. There are numerous systemic reactions in the body following a burn injury. Knowledge of the physiologic changes that occur during severe burns is critical for nurses who work with burn patients. In addition to the changes to the integumentary system that we've seen, burns cause significant changes in the cardiovascular, pulmonary, renal, and gastrointestinal systems. A burn injury causes a massive outpouring of catecholamines, which in turn cause the peripheral blood vessels to constrict. However, because of injury, these vessels have become more permeable, allowing fluids and colloids to leak into the surrounding tissues. The leaking fluid becomes trapped in the interstitial space, causing edema. If the burn is relatively minor, the edema is primarily local, producing a blister. When the burn is more extensive, this change in vascular permeability becomes a systemic response, causing edema throughout the body. Consequently, a relative hypovolemia or fluid volume deficit can occur within several hours. Hemoconcentration, as evidenced by the increase in hematocrit, causes blood to thicken and slow down. Alteration in blood flow can lead to altered peripheral tissue oxygenation and nutrition and venous stasis, possibly leading to further tissue destruction. This is known as the hypovolemic stage. Reduction in circulating blood volume decreases cardiac output and contributes to inadequate tissue perfusion. Cellular hypoxia shifts cellular metabolism from aerobic to anaerobic, with a net result of acidosis from the buildup of lactic acid. The pulmonary system is also affected due to the inhalation of carbon monoxide and potential airway obstruction. Carbon monoxide binds to hemoglobin more easily than oxygen and is only released in the presence of high partial pressures of oxygen. If large amounts of carbon monoxide have been inhaled, treatment with 100% oxygen will be required to prevent tissue hypoxia. Also, facial or neck edema caused by burns or smoke inhalation may cause airway obstruction and require intubation. Pulmonary edema may develop as a result of fluid shifts aggravated by fluid replacement therapy and hypoproteinemia. These problems subside when diuresis begins. The renal system also reacts to burn injuries. The hypovolemia that develops immediately after the burn occurs causes renal blood flow to decrease. This results in oliguria. Processing byproducts of cellular destruction can lead to glomerular or tubular damage. Burn patients with pre-existing renal disorders have a high risk of developing renal insufficiency during the post-burn period. The gastrointestinal system also reacts to burns. The hypovolemia induced by the initial burn injury may cause gastric dilation and paralytic ileus during the immediate post-burn period. This may resolve within 24 to 36 hours and then reappear. The burn patient is also at risk for developing a gastroduodenal stress ulcer known as Curling's ulcer. Patients with severe burns will go through several phases of treatment, including emergency care, acute care with or without surgery, and rehabilitative care. In the emergency room, care for burn patients will focus on life support, fluid support, and pain management. First, airway patency is assessed.
Okay, his lungs sound clear.
Respiratory management is especially critical for patients with carbon monoxide inhalation, airway burns, or chest wall burns. Determining the extent of burn injury is another important part of the assessment of the client with a burn injury. The extent of the burn can be estimated by using charts that show anterior and posterior views of the body. The most widely used tool to accurately assess burn area is this Lund and Browder chart. In adults, the extent of the burn can be roughly estimated by dividing the body into areas equal to multiples of 9%. The rule of nines assigns 9% of the total body surface area to the head and each arm, 18% to each leg, anterior and posterior trunk, and the remaining 1% to the genitalia. An accurate assessment of the burn area is important since all fluid resuscitation formulas are based on calculation of burn size. In the case of Kevin McDonald, his burns were classified as 20% total body surface area, mostly deep partial thickness with some full thickness on his wrists and shins. Fluid therapy is begun immediately by the intravenous route. The fluid calculation often used is the Parkland formula, which is 4 milliliters lactated bringers per kilogram of body weight multiplied by the percentage of burned body surface area, excluding superficial burns. This is infused over the next 24 hours in increments of 50% in the first 8 hours, 25% in the second 8 hours, and 25% in the third 8 hours. A Foley catheter will be inserted for hourly urine output measurement.
I'm going to listen to your stomach.
Nasogastric tubes may be inserted to remove stomach contents and prevent gastric distension until peristalsis returns to normal.
Normal active bowel sounds.
Intravenous narcotics for pain management are given in small, frequent doses. The total analgesic dose may be quite large.
Okay, take a
A
deep
tetanus
breath.
toxoid booster is also given in the emergency department. Burns are cleaned and the entire surface is assessed.
Take a nice deep breath.
Topical antimicrobials are applied to prevent infection. Usually, these are silver sulfadiazine or mafenide acetate. Patients with severe burns require lengthy and complicated care. A multidisciplinary team should involve occupational therapy, physical therapy, social services, dietitians, and pain experts, as well as doctors and nurses. Acute care of the burn patient begins once the patient is stabilized. 3 to 5 days following the initial burn injury, the patient enters the diuretic stage. During this stage, vascular leakage recovery is complete. Acute phase management includes a number of important assessments. It is important to assess the patient's fluid balance in order to monitor for effective fluid replacement. Assessment parameters include body weight, intake and output, and mental status. Assess wounds in detail for any signs of infection. Purulent drainage, abnormal color, foul odor, redness, or swelling in surrounding skin can indicate infection. Nutritional assessment should be performed, remembering that metabolism is increased following moderate to severe burns as a result of stress, fluid loss, fever, and infection. The daily protein requirement is greater than normal as a result of the negative nitrogen balance.
And you are eating, right?
Yes.
Nurses should also assess for any gastrointestinal complications by listening to bowel sounds. Assessment should also be done for peripheral tissue perfusion in the lower extremities, looking for signs of compartment syndrome such as pain, pallor, decreased capillary refill, diminished peripheral pulses, decreased sensation, and impaired movement. Full-thickness burn injury results in the death of the skin and subcutaneous tissue. This burn tissue, called eschar, is leathery and rigid in the early post-burn period. As edema fluid accumulates under the unyielding eschar, the stricture may severely decrease blood flow. If extremities are affected, this stricture may lead to ischemic gangrene and amputation. The eschar may be surgically cut to alleviate the stricture. Another important nursing assessment is that of the patient's psychosocial response to the burn injury. This area includes assessing the patient's self-concept and body image. The nurse should listen carefully for patient concerns about loss of function, scarring, disfigurement, changes in appearance, and healing. The patient needs to begin to adjust to the reality of his or her injuries and prepare for life outside the hospital. The nurse can support the patient's self-esteem through encouraging self-care and allowing the patient to make decisions about the plan of care. An important nursing diagnosis for burn patients is fluid volume deficit. This is related to third spacing from increased capillary permeability and fluid leakage in the wounds as evidenced by decreased urinary output and hypotension. An appropriate patient outcome is for the patient to maintain adequate blood pressure and urine output and avoid hypovolemic shock.
How are you doing today, Mr. McDonald?
I'm feeling better than yesterday.
Good.
For Mr. McDonald, the following nursing interventions were done during his first 24 hours of admission. Fluids were administered at 400 cc's per hour for the first 8 hours, followed by 200 cc's per hour for the next 16 hours. This fluid level keeps Mr. McDonald's urine output at greater than 30 cc's per hour and keeps his blood pressure stable. By day 3, the patient is also taking oral fluids and the nurse continues to assess for adequate fluid balance.
Your blood pressure looks good.
The nurse assesses Mr. McDonald for clinical signs of hypovolemia, such as reduced level of consciousness, changes in skin from pink to pale or from warm to cool, and decreased skin turgor.
Just hold nice and steady, Mr. McDonald.
Since weight is the most
Get your
accurate
weight.
measure of fluid balance, Mr. McDonald should be weighed daily and his weight compared to his pre-injury weight. The second nursing diagnosis is pain, related to injured and exposed nerve endings. Pain is exacerbated with treatments such as dressing changes, positioning, and wound cleansing. The desired outcome for the diagnosis of pain is for the patient to state that his or her pain is at a manageable or tolerable level.
Mr. McDonald, I'm going to change your medication syringe now.
Okay.
Okay?
Decreasing Mr. McDonald's pain will decrease his anxiety and increase his cooperation during dressing changes or other treatments. Pain medication should be timed with treatments and administered 30 minutes before dressing changes, hydrotherapy, and wound cleansing.
Has the medication been making you more comfortable?
Yeah, it seems to keep the pain tolerable.
On a scale from 1 to 10, 10 being the worst pain, what would you rate your pain now?
Right now, it's about a 5. During the dressing changes, it shoots way up to a 10.
Okay. Well, we'll have to make sure to give you a bolus of medication before your next dressing change.
Narcotics are given intravenously because peripheral vasoconstriction limits absorption of drugs given by IM or sub-Q routes. Another diagnosis is risk for infection related to impaired skin integrity and invasive procedures. The desired outcome is that the patient will not develop infections. The nurse documents the initial appearance of the burn wound, including color, dryness, and odor. Changes in the appearance of the wound may be the first signs of infection. Signs of infection include fever, increased respiratory rate, or a foul odor from the burns. The white blood cell count may be elevated or significantly depressed. Early detection of infection will allow for appropriate antibiotics to be prescribed as soon as possible. Sterile techniques must be used with all invasive procedures, including IVs, dressing changes, and Foley catheters. Performing wound care for the burn patient involves both wound cleaning and protection of the wound. This care is usually done twice a day. The wound must be kept clean of debris and dead tissue, which increase the threat of infection. Removal of non-viable tissue is called debridement. Debridement may be performed surgically one or more times during a patient's hospitalization. Debridement is also performed mechanically by the nurse using enzymes, irrigation, or dressings. Proper timing of pain medications will make the experience more tolerable for the patient. Once the wound has been cleaned, it needs to be protected. Both open and closed wound methods are used. In the open method, topical creams or ointments such as antimicrobials are applied and then left to the air. In the closed method, bandages are soaked in or impregnated with antimicrobial and then covered with a thick dressing. These bandages are changed daily. Bed cradles are frequently used to keep linens from rubbing burn dressings and are required if open wound methods are used. With deep partial thickness and full thickness burns, grafts are applied to cover the burn wound and speed healing, to prevent contractures, and to shorten the patient's convalescence. Grafts may be done in several ways. Temporary grafts of up to a week can be used from cadavers, and these are called allografts. Grafts known as xenografts are grafts of skin obtained from animals such as pigs. Synthetic substitutes for skin are also being investigated. These temporary dressings are left in place just long enough to stimulate skin healing and regrowth. The advantage of temporary grafts is to reduce water, electrolyte, and protein loss at the burn surface. Temporary grafts are used until the patient is ready for autografts. Autografts are done using unburned skin from other parts of the patient's own body. There are two types of autografts: split-thickness skin grafts and full-thickness skin grafts. Split-thickness grafts are taken only through some layers of the epidermis. They are only 8 to 12 thousandths of an inch thick. Split-thickness grafts survive well and heal quickly, but do not give very good cosmetic results. Full-thickness skin grafts are used in areas such as the face, where the best cosmetic effect is desired. These grafts are also used to cover areas where optimum function is needed, such as the palms of the hands. Autografts can be applied as either sheet grafts or mesh grafts to the recipient bed. Sheet grafts are applied just as they are harvested and are often used in areas that undergo the most stress, such as joint areas. Sheet grafts are laid on the wound and secured with staples or sutures. The graft is fully adhered 5 to 7 days after surgery. With meshed grafts, a mesh pattern of small slits is created. The meshing allows the donor skin to be expanded to cover a larger surface area than the original donor site. These created holes allow the wound to drain. If the grafts are left open, they must be kept moist with an antimicrobial agent. Mesh grafts are fragile, and so motion to the area should be minimized. Gentle range of motion of the grafted part may safely be started 5 to 7 days after surgery, but care must be taken to avoid shearing forces on this area. In addition, there is a new technique of culturing epithelium. Small biopsies taken from unburned skin are placed on a growth medium and will grow to between 50 and 70 times the size of the initial sample. The skin is adhered to a backing of Vaseline gauze and surgically applied to the burn wound. Donor sites may be covered with a variety of dressings: semi-permeable dressings, fine mesh gauze, or synthetic dressings are used to protect the donor site during the healing process. These areas can be fairly painful for the burn patient. The donor site with the gauze is exposed to air.
Occasionally, a heat lamp or a hairdryer on a low setting is used to help the donor site dry. These donor sites heal in 1 to 2 weeks. The gauze should not be removed. You should wait for it to fall off. One of the possible effects of a full-thickness burn is hypertrophic scarring. With hypertrophic scars, also known as keloids, the scar becomes elevated and is extremely thick compared to normal skin. Elastic wraps, individually fitted pressure bandages, or custom-made pressure garments can be applied to burned areas to decrease hypertrophic scar formation. Unfortunately, these elastic garments may be uncomfortable, but must be worn constantly and removed only for bathing. This practice continues for 1 to 2 years until the scar is fully mature. With scar maturation comes an increase in physical functioning, improved appearance of the skin, and improved skin sensation. Another important nursing diagnosis for a burn patient is that of altered nutrition, less than body requirements related to the increased caloric demand of burn injury. The desired patient outcome is for the patient to maintain caloric intake sufficient to promote healing and maintain ideal body weight. Patients with major burn injuries need about twice the usual number of calories and 3 times the protein.
Then why don't we just include milkshakes with his meals in addition to in-between meals?
The dietitian is the expert in this area and a valuable member of the burn team, so it's important to consult with a dietitian regarding dietary allotment. Pain and medications commonly diminish appetite, so be sure to assess the level of pain before eating. Also, schedule potentially painful procedures to avoid meal times. Other diagnoses for a burn patient include impaired physical mobility and alteration in body image. The burn victim's reemergence into society depends on several factors. The degree of disfigurement from the burn will have a major impact on the patient's psychological adjustment. In addition, the patient's education, vocational rehabilitation, and outpatient care can all affect the reintegration into society. Some patients become frustrated with the long rehabilitation period, and all patients are concerned about their perception by others. An accepting environment with adequate family support usually allows the patient to finally accept the body changes that followed the injury. The nurse can refer the client to professional counselors and support groups for people with burn injuries. As we've seen, the nurse's role in working with burn patients is a complex one. Patients and their families will need physical and emotional support over a lengthy period of time.
For additional reference in medical surgical nursing, Mosby recommends Mosby's Clinical Nursing by Thompson.